a very good afternoon to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, before moving to the topic of the day, we will be first introducing our honored speaker, who is none other than Professor Dr. Kiran Patule, sir. Sir is MBBS, MD in Ops and Gyne Fellowship, FICMSH, ICMCH, Professor and HOD of Obstetrics and Gynecology at MPGMR, Nasik. With such wonderful insights, we are going to talk about the topic for today, which is ectopic pregnancy, diagnosis and management. Before moving on to today's session, let us have a brief look on what the topic says. So, an ectopic pregnancy occurs when a fertilized egg implants and grows outside the main cavity of the uterus, typically in one of the fallopian tubes. In this in depth webinar on ectopic pregnancy diagnosis and management, we will be providing comprehensive insights into the diagnosis, treatment, and management of ectopic pregnancy, a critical condition that requires prompt and accurate intervention. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you. Please proceed.
Good afternoon, everyone. So today's topic for discussion is diagnosis and management of the ectopic pregnancy. As you all know, ectopic pregnancy results when the fertilized ovum gets implanted in a abnormal site other than the normal uterine cavity. Day by day, worldwide, the incidence of ectopic pregnancy is on rise, and the reasons are obvious because the predisposing factors which we are going to discuss, like the incidence of PID, then more and more pregnancies are happening because of IVF or artificial reproductive techniques, which make the incidence on a higher side. In spite of that, the mortality is decreasing, and this may be because of the early detection of this ectopic pregnancy. But still, it contributes to around 15% of the maternal deaths, and which is around 10 times higher than the normal vaginal delivery. There are certain known risk factors as a causation for ectopic pregnancy, like tubal damage, which may be because of infection or previous surgery, like tuboplasty, even tubectomy, endometriosis, then history of infertility, artificial reproductive techniques or IVF, nullipara, smoking, hormonal use, for example, the progesterone containing contraceptives, or previous history of ectopic. So these factors are known to cause chance of ectopic pregnancy. Then amongst all the sites where the ectopic pregnancy can happen, the commonest site is the fallopian tube. And in the fallopian tube, again, the ampullary portion of the fallopian tube is the commonest site for these ectopic pregnancies. The next common site are the ischemic portion of the fallopian tube, then the femoral portion. Then we have some rare sites where the ectopic pregnancy can take place, which is like interstitial pregnancy or cervical pregnancy, ovarian pregnancy, or very rarely there can be abdominal pregnancy, which may be primary or secondary. When there is ectopic pregnancy at any of these ectopic sites, it has certain course. It may spontaneously resolve without doing anything, even the patient do not have any symptoms. It has its natural regression, or especially in ampullary or femoral pregnancy may get aborted and which gradually resolves, but the ectopic site may trickle or which may gradually stop trickling and which may result in hematosalpinx. Or if it continues up to certain extent and finally the tube will rupture, so which occurs earlier in case of ampullary or ischemic pregnancy, while in interstitial pregnancy, the tubal rupture occurs little late, and the presentation may be acute or chronic. After tubal abortion, that pregnancy may continue to grow at the other ectopic site in the abdomen, and which may result in the secondary abdominal pregnancy. Then the clinical presentation of the ectopic pregnancy varies right from asymptomatic to asymptomatic, and the common symptoms are amenorrhea, which will be seen in around 80% of the patients. In around 20% of the patients, you may not get the typical history of amenorrhea, and this is because when the ectopic pregnancy gets dislodged from its implantation site, there is parovaginal bleeding, and which many times is taken as the menstrual cycle. So you don't get history of amenorrhea in around 20% of the cases. Then abdominal pain is another common symptom which is seen in around 90% of the patient. That abdominal pain is typically on the lateral side of the abdomen. Then the third one is vaginal bleeding, which will be seen in around 70%. This classical triad, that is amenorrhea, abdominal pain, and vaginal bleeding, will be seen in around 30% of the patients. And in total, around 60% patients will be symptomatic, and another 40% of the patient may not have typical symptoms. So there is a wide spectrum from asymptomatic to the patients who are you receive in shock. Then adnexal tenderness will be elicited in around 55% of the patients. Adnexal masses will be felt in around 10% of the patients. Then other common symptoms are dizziness, expulsion of the decidual cast, symptoms of acute abdomen. Then you may get typical shoulder tip pain, which will be seen when there is a free fluid, that is blood collected in the abdomen more than 500 cc. So there is always importance of early screening. By early screening, you can detect it in the earlier stage before rupture, and the further morbidity or mortality can be avoided. So for that, what you have to do is suspect ectopic in a reproductive age whenever there is a delayed menstruation with pain, or when there is a history of painful defecation. Consider screening for ectopic if any of the following factors is elicited, like infertility, pelvic inflammatory disease, previous ectopic, tubal surgery, if there is a issue of conception with ART, or intrauterine device is there. The screening reduces the rupture chances of rupture from 2.1 to zero point 0. So, for diagnosis of ectopic pregnancy, history and physical examination is 60% accurate. So, what do we have in a diagnostic test for diagnosing the ectopic pregnancy timely? So, in that, we have serial beta HCG, transabdominal or transvaginal sonography, serum progesterone, uterine curettage, laparoscopy just for diagnosis usually is unnecessary except you want to do a surgical intervention or the treatment is simultaneously needed. Then what are the clinical recommendations for practice in ectopic? We should not rely on any combination of physical examination findings to exclude ectopic. Ultrasound should be a part of initial evaluation, and if transvaginal ultrasound does not detect intrauterine pregnancy, presume that ectopic pregnancy is virtually certain if beta HCG is more than 1500. So, what are these beta HCG levels in case of intrauterine pregnancy, so that we will see how it differs in case of ectopic pregnancy? Beta HCG becomes positive in 7 to 10 days and peaks at around 50 to 70 days in case of normal intrauterine pregnancy. The level varies throughout the pregnancy. The rise of beta hCG levels correlates with the embryonic growth, and the doubling time, which is very important for as far as in the diagnosis of ectopic pregnancy. The doubling time in normal pregnancy, regardless of its initial level, and it is 48 hours in 85% of the intrauterine pregnancy till sixth week of the pregnancy. So the normal intrauterine pregnancy within 48 hours, there is 66% rise in the levels of beta hCG, and within 72 hours, the rise is 114%. How it differs in case of ectopic pregnancy? The beta hCG is again virtually positive in all ectopic pregnancies, but the beta hCG rise is less in ectopic pregnancy. In 85% of the cases, they will have of ectopic pregnancies, they will have less than 66% rise in 48 hours, which you will expect in normal intrauterine pregnancy. The subnormal doubling time usually is more than 7 days, and at 48 hours, 40% have either decrease or 45% will have subnormal rise. And in around 15% of the ectopic pregnancy, they will show the same rise as in intrauterine pregnancy. Then the role of ultrasonography. It has a key role in diagnosing ectopic pregnancy to for evaluation of endometrial cavity, adnexa, and the peritoneal fluid. Both transvaginal and transabdominal sonographies, they are important. Transvaginal sonography will typically detect the pregnancy 1 week earlier. It will give better visualization, and it will provide better assessment of even PID. While transabdominal sonography will offer you bigger picture, it helps you in detection of the unusual sites and assessment of the peritoneal fluid, that is hemoperitoneum. So, how these ultrasonography findings are to be interpreted? When you can see the intrauterine sac with the fetal pole and the cardiac activity, there is a definite intrauterine pregnancy. But if the uterus is empty with endometrial thickness less than 6 mm, then you presume that there is no definite intrauterine pregnancy. When you see sac with no pole or irregular sac, then obviously it is either missed abortion or incomplete abortion. When there is a ring-like sac with pole and cardiac activity outside the uterus, it is definite ectopic pregnancy. And when you see dual ring, that is Bengal's ring, with adnexal mass and the peritoneal fluid, it may be probable ectopic pregnancy because such adnexal masses may be because of other conditions like, say, ovarian mass or fibroid, and which may mimic in the ultrasonographic presentation. How one should correlate this ultrasonography finding with beta hCG levels? Because single finding either with ultrasonography or by beta hCG may not many times conclude. If on transvaginal sonography, if you don't see intrauterine pregnancy and the beta hCG levels are more than 1500 international units, you presume that the ectopic pregnancy is there. But still, there are certain problems in interpretation of the ultrasonography findings. And which are these problems? Sometimes you may see a pseudo sac, and which you, by mistake, you take it as a intrauterine pregnancy. How to differentiate the pseudo sac from the normal pregnancy? This pseudo sac is usually located at the center, and there is no DDSS sign, that is double deciduous sac sign in case of pseudosac. Then very early pregnancy may be missed on ultrasonography because you may do the screening very early and the sac may not be visible. Absence of intrauterine pregnancy with beta hCG above discriminatory zone does not confirm ectopic or abortion, then interstitial pregnancy, you should be diagnosed with myometrial mantle and eccentric interstitial line sign. In case of heterotropic pregnancy, that is, you get ectopic pregnancy along with the intrauterine pregnancy, there is a problem in interpreting these beta SCG levels as well as on ultrasonography, because both will be positive, like say intrauterine pregnancy and the ectopic pregnancy. Other adnexal masses like corpus luteal hematomas, which may mimic the presentation or the picture on ultrasonography like ectopic pregnancy. What are the other tests which will help you in a diagnosis? One is dilatation and curettage, which should preferably be avoided because sometimes you may disturb the normal intrauterine pregnancy. It may sometimes help you to differentiate ectopic pregnancy from non-viable pregnancy, to check the villi with normal saline and if needed by histopathology. Then serum progesterone levels, which again have limited usefulness. If the serum progesterone levels are more than 25 nanogram per ml, then viable intrauterine pregnancy is presumed. If the serum progesterone levels are less than 5 nanogram per ml, then you assume that the pregnancy is non-viable, but it doesn't confirm that it is ectopic or intrauterine. Then sometimes you may have to do a culdocentesis, that is, puncture the posterior fornix with a big bore needle. And if you get a non-clotted blood, that indicates that there is a ruptured ectopic pregnancy. So the diagnostic workup is done like in suspected cases, you do serial beta ECG above discriminated zone, and if you don't get no intrauterine sac, then it is definite ectopic pregnancy. If the levels are below discriminated zone, repeat beta ECG. If the rise is more than 66%, it is early viable pregnancy. And if there is a subnormal rise or fall, then it is either it is a non-viable pregnancy or ectopic pregnancy. Serum progesterone levels to rule out viable pregnancy. Uterine curettage to rule out abortion. Then there are certain surgical conditions which you may have to differentiate from the diagnosis of ectopic pregnancy, like all the conditions which present with acute abdomen, like say splenic rupture or perforated appendix, perforated gastric or duodenal ulcer. In all these conditions, you typically get board-like rigidity, which usually is absent in case of ectopic pregnancy, because the tenderness or the pain you get in ectopic pregnancy is usually on the lateral side. Then the pervaginal bleeding, which is again a constant sign in majority of the cases, will be seen in ectopic pregnancy, will be absent in all these conditions. The another common condition which will mimic in the presentation is the rupture corpus luteal hematoma, and majority of the negative laparotomies are done with the diagnosis of ectopic pregnancy, and it turns out to be a corpus luteal hematoma. Then miscarriage, the pain or pervaginal bleeding, which is again common symptom in both the conditions. Salpingitis, even here again the pain, tenderness, or the adnexal mass you may get in case of fallopian tube conditions. Then torsion of the ovarian cyst, intrauterine contraceptive device, red degeneration of the fibroid, or rupture of the chocolate cyst. All these conditions may mimic in the presentation like ectopic pregnancy. Then how one should evaluate these suspected or diagnosed cases of ectopic pregnancy? The further evaluation depends on whether the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, then definitely you should not wait further. You should subject her for further confirmative diagnosis or definitive treatment like with surgery, either laparotomy or laparoscopy. But if the patient is stable and if the diagnosis is not confirmed, then you further evaluate her with serial beta ECG, ultrasonography, or serum progesterone levels, which will either lead you either with viable pregnancy or heterotropic pregnancy, or will tell you regarding non-viable pregnancy or ectopic pregnancy, which may be confirmed with help of dilatation and curettage. With the presence of villi, if they are present, it indicates that it is a non-viable pregnancy. But if the villi are absent, then it hints towards ectopic pregnancy. Again, these are to be managed with surgical intervention. Then, after confirmation of the diagnosis, what are the treatment options? The treatment options are commonly the surgical treatment, either by laparoscopy or laparotomy. And with both these methods, either the treatment can be conservative, like salpingostomy, or radical, that is salpingectomy, where you remove the fallopian tube, damaged fallopian tube. Then another important option is where you can avoid surgical intervention is medical treatment. Then it can be surgical assisted medical treatment with help of ultrasonography, laparoscopy, or hysteroscopic guided medical intervention. Or there can be fourth option, that is expectant management. You have to just monitor and you expect that the ectopic pregnancy may resolve. How to select the surgical intervention versus the medical line of management? Because both are equally effective, but you have to properly select the patient, and which depends on the clinical circumstances and the site of ectopic pregnancy. Surgery is preferred if the tubes are ruptured, or if the patient is in hypotension, has severe anemia, or if the pain persists for more than 24 hours and not suitable for medical management. And this assessment is done on these five parameters, that is levels of beta ECG, progesterone levels, abdominal pain, hematosulfings or the sac size, and hemoperineum, the quantity of hemoperineum. And the score is given for each parameter, and if the total score is less than 12, then only you can go for medical line of treatment. If the score is more than 12, then you don't have a choice of medical management. All these patients are to be subjected for surgical line of treatment. Then how to select laparoscopy versus laparotomy? The laparoscopy nowadays is the gold standard, which offers shorter hospital stay and convalescence. It has lesser operating time and blood loss. L- But still, laparotomy is preferred when the patient is hemodynamically stable, where you can cut short the time. The surgeon who is not conversant with the laparoscopy should go for laparotomy. If there is some equipment problem, laparoscopic approach technically is difficult in certain cases. And when you expect large blood clots or extensive adhesions in the pelvis, then again the option of laparoscopy is not preferred. Then salpingectomy versus salpingostomy. So salpingostomy is done when in the intention to conserve the tube for further fertility. Salpingectomy is done if the ruptured and uncontrolled bleeding is done, When there is extensive tubal damage, if there is a recurrent ectopic, if the fertility is not to be preserved or the patient has completed the family, previous reconstructive surgery is there, or there is a large tubal pregnancy when the sac size is more than 5 centimeter. In all these conditions, you should not go for salpingostomy, but you have to go for uh, removal of the tube. The salpingostomy is the procedure where you have to where you cut open the sac and remove the uh, conception. It is always a linear salpingostomy, and the incision is taken at the antimesenteric border of the tube. Before that, you have to do hydrodissection, and the bleeding points are well secured, and try to conserve the tube. This is the picture where laparoscopically the, the salpingostomy is being undertaken. The same. Then the next option, that is medical management. There are certain eligible criteria for selecting patients for medical management. The first important criteria is the patient has to be hemodynamically stable and the ectopic pregnancy is unruptured. The diagnosis has to be confirmed. Second, the patient has to be reliable and compliant, because you need to follow her closely when the patient is selected for medical line of treatment. There should not be any contraindication for methotrexate, which you are going to use for medical line of treatment. Then the blood count, even the liver and kidney function test should be normal. The sac diameter should be preferably less than 4 centimeter, and there should not be preferably no cardiac activities in the sac. The beta HCG level should be preferably less than 6,000 international units per liter. So you get around 30 to 40% diagnosed patients of ectopic, which can be eligible for medical line of treatment. Then what are the contraindications for medical line of treatment? So obviously ruptured ectopic, then larger ectopic pregnancy where the sac diameter is more than 4 centimeter. If the pain persists for more than 24 hours, laparoscope is required for diagnosis. So when you need laparoscopy for diagnosis, then obviously you will complete the procedure by laparoscopy only. Then suspected ectopic pregnancy. So in that case, you should not go for medical line of treatment. Then if there are any contraindications for methotrexate and poor patient compliance. Obviously, there are certain advantages with medical management, that these are: there is no risk of surgery and anesthesia, no patient discomfort, expense of the surgery is avoided, and it can be done on OPD basis. And it, at the same time, it gives similar results like salpingectomy or salpingostomy. Further, fertility is not affected, but there is certain checklist you have to make before you go for medical line of treatment. What is that? You have to obtain beta HCG levels at the baseline. Then transvaginal sonography is to be done. Uterine curettage if you suspect non-viable pregnancy. Hemogram, blood urea level, creatinine, SGOT, SGPT, and total bilirubin is to be estimated. Confirm ectopic pregnancy, which is unruptured. Informed consent is to be taken for any time you may have to go for a surgical line of treatment. Then administer anti-D if the patient is Rh negative, and schedule follow-up visits right when you start the medical line of treatment. Then what exactly you do in a medical line of treatment? So usually it is a single dose treatment. On day zero, you go for CBC liver function test, kidney function test, beta HCG levels. Then on day one, you have to administer 50 milligram per meter square of the methotrexate. On day 4, repeat the beta HCG levels, which may be higher than day 1 or day 0. Then again repeat the beta HCG levels on day 7, where you expect the beta HCG levels by more than 15% between day 4 and day 7. If you don't find fall in the beta HCG level, repeat the dose in the same way. Then follow same schedule. On day 14, again you have to repeat the beta HCG levels. If you don't find any effect, that is fall in the beta HCG level or reduction in the sac diameter, then option left is only surgical intervention. Then patient need to be given certain instructions when she is on medical line of treatment. She should not consume any multivitamin or folic acid tablets, no alcohol intake, avoid drugs like salicylic acid, tetracycline, or phenytoin. She should abstain sexual intercourse, avoid exposure to sun, and she must inform if she experience heavy bleeding or prolonged bleeding. If the pain persists for 3 to 7 days for more than 4 to 12 hours, or if there is persistent pain for more than 12 hours, and how the patient should be monitored. The monitoring can be done on outpatient basis, or if the patient is non-compliant or the patient's symptoms are severe, then she can be made indoor. Do hematocrit. Transvaginal sonography is usually not helpful. Most unruptured also may show free fluid in the POD. Differentiate pain due to effect of the treatment or rupture. Even if there is a pain, 79% will do not require any surgery, because this pain may be because of the as an effect of the treatment. Resolution usually takes 5 weeks to maximum 7 weeks after starting the treatment, and the treatment effect will be seen in the form of abdominal pain. There may be an initial increase in the beta ICG levels or vaginal bleeding. When you have to intervene with surgery, if there is a prolonged pain for more than 24 hours, if the pain is very severe or it hints towards tubal rupture or impending tubal rupture, if there is fall in the hematocrit or patient herself no longer wants to continue with the medical treatment, or when there is a failure of the medical therapy, what is the risk of tubal rupture? The tubal rupture highly depends on certain factors. First is higher the beta HCG levels, which are if they are more than 10,000 international units per liter, there will be 32% chances of tubal rupture. And if they are less than 10,000, there will be only 3% chances of tubal rupture. If the cardiac activity is there, obviously there will be more chances of tubal rupture, and the tubal rupture is less likely if the tubal mass is less than 2 centimeter in diameter and beta HCG levels are less than 2000 international units per liter. But sometimes, very rarely, you may get the cases where the tubal rupture may be seen with falling HCG, even with beta HCG levels less than 5 international units. And the treatment failure can occur even with beta HCG less than 50 international units. Then what should be done? Shall we go for a medical line of management with cardiac activity? As we have already mentioned that it is relative contraindication. So there will be threefold increase in the risk of tubal rupture. So there will be more chances of failure. So in such case, if at all you want to go for a medical line of treatment, it should be a local medical line of treatment with systemic. which will give you 91% of the success rate. So in this 12 milligram of methotrexate it is injected in the sac by ultrasound guided along with systemic methotrexate and with min beta ECG 12,000. So in whom you can go for expectant line of treatment. A reasonable option of carefully selected cases, which may be only 15 to 20, but they can be managed with expectant line of treatment. And the inclusion criteria for expectant line of treatment is the absence of more than minimal pain. Either there may be absence of evident tubal rupture, absence of free fluid, the ectopic mass is less than 3 centimeter in diameter, beta ECG levels are less than 1000 international unit, and no fetal heart activity. Overall success rate with expectant liner treatment is 70%, and if beta ECG levels are less than 1000, it is 80%. Then, how the rear sites ectopic pregnancy is to be managed. The first one is the interstitial pregnancy, which accounts for 4% of all the ectopic pregnancies, and which is seen in 1 in 5,000 live births. So, the typical presentation in the interstitial pregnancy is that there is a late rupture. Usually, the pregnancy may continue to around 12 weeks size because it happens at the thick portion of the fallopian tube. So, it doesn't rupture as early as in cases of ampullary or ischemic ectopic pregnancies. It will be common with previous salpingectomy. In around 25% of the cases, you'll get history of salpingectomy already done. Diagnosis by ultrasonography will be done by typically finding myometrial mantle with interstitial line sign. The treatment is undertaken by local and systemic methotrexate or with laparotomy. Sorry. Abdominal pregnancy, the incidence is of around 1.4% in all ectopic pregnancies, or which will be seen in 1 in 8,000 live births. The mortality is 5 per 1,000, and which is 7 times higher than in ectopic pregnancies and 90 times higher than intrauterine pregnancy. It can be primary or secondary, which is more common. The diagnosis of primary abdominal pregnancy is by Studford criteria, where there are three important points where the tubes and the ovaries should be normal in appearance. There should be no uteroplacental fistula and presence of pregnancy related to peritoneal surface. The treatment is usually surgical, and the main difficulty in tackling this abdominal pregnancy is the fetus, even if it is grown up to certain extent, it can be removed or the adhesions can be separated. But the main difficulty is in removing the placenta. In that case, what you have to do is you have to leave the placenta and cut the cord as flush to the placenta as possible. And later on, you can give methotrexate. Then another rare type of ectopic pregnancy is the ovarian pregnancy, which accounts for 1% of all ectopic, which will be seen in 1 in 7,000 or 40,000 live births, and 30% of the patients are hemodynamically unstable. It is not associated with PID, and there is no usually history of infertility. In 20 to 90% of the patients, it is associated with intrauterine device. There is no case of recurrent ovarian ectopic. And the diagnosis of ovarian ectopic is by Klingenberg criteria, which is intact fallopian tube, fetal sac in a position of ovary and the ovarian tissue in the sac wall, and the ovary is attached to the sac with the uterus with the ligament. Then another rare type of ectopic pregnancy, the cervical pregnancy, which is seen in around 0.15 per contributes to 0.15% of all ectopic cases, and which will be seen in 1 in 12,000 live births. The predisposing factors are repeated diastasis in around 68% of the cases, history of in vitro fertilization or Asherman syndrome, typically with cervical enlargement and the globular shape of the cervix. On USG, you find a gestational sac which is in the cervical canal and below the internal os. And the treatment is undertaken, usually it is surgical intervention by either doing cervical encerclage or tackling it with hysteroscopy or embolization or with methotrexate. In case of heteropic pregnancy, so I beg your pardon, but it is unable to go for details of this rare type of ectopic pregnancies because of the shortage of the time. So I'll just go through the important points. In case of heteropic pregnancy, which is again very, very rare, 1 in 30,000, and but it is very common in ARTs, around 1%. There are several diagnostic pitfalls because there is intrauterine pregnancy as well as ectopic pregnancy. So the way both the clinical signs or the test you may get the combination. The serial beta ECG are not helpful. Laparoscopy is required to diagnose and confirm, and medical line of management is not undertaken. So, to conclude, early diagnosis is a contributing in increased incidence because many of the ectopic pregnancies which can be diagnosed otherwise they may be missed without any symptoms. Risk factors continue to be prevalent. Diagnosis is possible before symptoms. Early diagnosis made amenable to medical therapy. Thank you. Thank you for patient hearing.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about the topic in such a better manner. Moving ahead with the question and answers round, so we have received a few questions from the participants. So, with all your due permission, I would like to put across those questions to you.
Yes, please.
Yeah, so the first question is related to the potential complications. So, what are the potential complications associated with ectopic pregnancy and its treatment?
The potential complications with ectopic as such, if it is the diagnosis is delayed, obviously the patient will bleed inside with rupture, and the patient will be in shock, and further she will deteriorate. Again, with treatment, usually if the patient is unstable, you have to go for the immediate surgical intervention. But if you are thinking of medical line of treatment, as I have already mentioned, there is always chances of rupture when the patient is on treatment. So she has to be with close monitoring. So even if the patient is on medical line of treatment, the chances of further deterioration or rupture are there.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question and the last question before we conclude. And the question is related to the differentiation. So, how do one differentiate between an ectopic pregnancy and other causes of acute pelvic pain in reproductive age women?
Yes. So in the differential diagnosis, I have already mentioned the common conditions or surgical conditions which we mimic in the presentation is all the conditions which present with acute abdomen, like say a rupture of spleen or hemopuritinism because of any other condition. So it may be a splenic rupture or perforation of the appendix. So in all these conditions, you get typical board-like rigidity. While in ectopic pregnancy, the pain or the tenderness is on the lateral side localized. Then pervaginal bleeding will be absent in case of the other conditions, which will be seen in ectopic pregnancy. So these are clinical signs, but still you may sometimes miss. Each ectopic pregnancy, as many of the will agree that it has unique presentation. You many times you don't get typical signs or clinical presentation.
Thank you so much, sir. Thank you for such an elaborative talk and for making our viewers understand about it. With this, I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights. Thank you so much, sir.
Thank you.
So, with this, we would like to conclude the session here for today. Until next time. Thank you, sir.